Well, first, I'd like to thank everyone, Loenneke, and for setting this up. It's a great honor to speak alongside Dr. Petterson, who's done a tremendous amount of work in this area. So I'm excited to be here to speak about this today. When we think about normal circulation, just normal blood flow, we have arterial flow into the muscle, and we have venous flow out of the muscle. With blood flow restriction, that involves placing a cuff at the very top of the limb, in this case, the arm, and we inflate it to a pressure where we slow down blood flow into the limb and largely occlude blood flow out of the limb. So importantly, blood flow is always coming into the limb. When this is combined with exercise and repeated consistently, two of the adaptations that commonly are observed are changes in muscle size as well as changes in muscle strength. Now, blood flow restriction training is a topic that's really been increasing in popularity as of late. On the y-axis here is a number of citations for blood flow restriction training in a very popular research search engine. On the x-axis is the date across time, starting with the earliest paper related to this topic that I'm aware of, at least, in 1998 up to last year. So you can see over the past few years, the number of citations for this has really increased quite a bit. But it's important to also think about it from a historical perspective. I'd say one of the people who really made this training popular was Sato from Japan. And he's actually been self-experimenting with blood flow restriction for quite some time. And he's the one that kind of developed his own kind of training principles related to this. He calls it the Katsu training. He developed his own company, his own special cuffs, and actually generalized his methods for the general public in the 1980s. So blood flow restriction training has been around for quite some time. The first published paper on blood flow restriction, as we think about it, was published in 1998 by Shinohara and colleagues in the European Journal of Applied Physiology. They used a within subject design, and they were interested in investigating whether or not combining low intensity exercise with blood flow restriction, whether or not that could increase strength over the same exercise without blood flow restriction. When we look at the change in strength on the y-axis, with those two separate conditions on the x-axis, blood flow restriction in red, the control condition in blue, we can see that in response to low intensity exercise with blood flow restriction, there is an increase in strength, which is greater than that of a condition doing the same exercise without blood flow restriction. And this highlights, and was one of the first to highlight, a potential treatment effect of blood flow restriction. One of the common questions related to this is whether or not blood flow restriction is actually safe. And I think that's an important question. And generally, the two areas that people are concerned with are related to coagulation activity. In other words, does performing this type of exercise increase your risk for blood clots, as well as muscle damage? So do you get more muscle damage when you exercise with blood flow restriction? And the available literature to date would suggest that when blood flow restriction is combined with low load or low intensity exercise, that it produces a very similar response to that of just regular exercise. In other words, it doesn't appear to increase your risk over doing the same exercise without blood flow restriction. Now, admittedly, the majority of the safety work has been completed in normal, healthy individuals, but there is some data on clinical populations that also suggest that it appears to be relatively safe. So I think, relatively speaking, I think blood flow restriction can be applied safely, and it does not appear to increase your risk more than that of the same exercise without restriction. Now, the populations who may benefit the most, I think it's important to note that blood flow restriction has been investigated across a wide range of populations. and it's been shown to be beneficial in those who are young, young untrained, young trained, athletes, non-athletes. The two populations I have listed here are those I think could probably benefit the most. So in other words, older adults who may be unable or unwilling to lift at higher training loads that are typically associated with favorable changes in muscle adaptation, as well as rehabilitation, which I think Dr. Petterson is going to focus on, at least in part of his talk. So I think that this population may be able to utilize some of the restorative properties associated with blood flow restriction. Pictured here is Dwight Howard. He's a basketball player in the NBA. And this is him doing blood flow restricted exercise. They did a story about him a few years ago on ESPN. And relatively speaking, he's older as it relates to athletes in the NBA. And he was talking about how he kind of preferred this method of training because he felt like he could recover a little bit faster for his actual sport, which is basketball. Now, I think blood flow restriction is best described and best discussed as three separate phases of blood flow restriction. And I'll talk about each one of these individually. But the first phase is the application of blood flow restriction in the absence of muscle contraction. The second is blood flow restriction in combination with low intensity aerobic exercise. And then the last phase is resistance exercise in combination with blood flow restriction. Now, the first phase would look very similar to this. The cuffs would be placed at the very top of the leg, and they would just undergo a series of inflations and deflations. And importantly, this is done in the absence of muscle contraction. So the cuffs just go at the top of the leg, they're inflated for a series of minutes and then deflated. And really the first paper to look at this was a paper by Takarada and colleagues, where they were investigating individuals who had just had ACL surgery. And they looked at two separate groups. So they took individuals who had just had surgery. Some of them went to the blood flow restriction group, where they had a series of inflations and deflations. Importantly, no muscle contraction. And the other group went to a control. And Takarada was interested in the change in muscle size from day 3 post-surgery to day 14 post-surgery. And when we look at the change in muscle size of the knee extensors on the y-axis here, with those two groups on the x-axis, the control in blue and the blood flow restriction in red, we can see that in response to ACL surgery, there is a loss of muscle size. However, it appeared that blood flow restriction was able to slow down some of that muscle loss, suggesting potentially a treatment effect as it relates to maintaining muscle size. With respect to strength, that was answered by Kubota in 2008. For their study design, they used 14 days of cast immobilization. So these individuals did not have surgery. They were immobilized via cast. And they were interested in 3 separate conditions. The first, blood flow restriction. Again, just inflations and deflations, no contraction. A group undergoing brief isometric contractions, and then just the control. And they were interested in the change in strength from before casting to 14 days later. When we look at the change in strength on the y-axis, again with those 3 groups on the x-axis, the control in blue, isometric in gray, and blood flow restriction in red, we can see that in response to 14 days of cast immobilization, there is a loss of muscle strength in both the control group as well as the isometric training group. However, the group that was undergoing a series of inflations and deflations appeared to largely maintain a lot of their strength. Now, what I show you here is isometric strength, but this was true of the other strength tests that they used as well. Again, suggesting that inflations and deflations may be able to maintain some of this muscle function. Now, mechanistically, it's not really known how that might work. One of the ideas that was put forth is a swelling-induced anabolic effect. In other words, when we apply blood flow restriction, we cause the muscle cell to swell, which is thought to potentially lead to mTOR activation and ultimately favorable changes in protein synthesis. However, a recent study suggests that maybe that might not be occurring. So on the y-axis here is the myofibrillar fractional synthetic rate, and on the x-axis we have, again, control in blue and blood flow restriction in red. This group's found that in response to inflations and deflations without muscle contraction, there actually is no augmentation in the protein synthetic rate over a control group. And this might suggest that if blood flow restriction by itself really can slow down muscle loss, if it really can help maintain function, that maybe it's working through mechanisms other than that would increase synthesis. So perhaps it's working more on the protein breakdown side of things. But ultimately, we need a lot more data to really understand this phase. The second phase is the combination of low intensity walking or cycling in combination with blood flow restriction. It will look very similar to this with aerobic exercise. The cuffs would be placed at the very top of the limb, and they'd be inflated to a subocclusive pressure. Now, one of the first papers to look at this was a paper by Abe and colleagues in 2006. They investigated the effects of walking very slowly on a treadmill at 50 meters per minute. And they had one group walk very slowly in combination with blood flow restriction, and they had another group that just walked slowly. And they were interested in the change in muscle size from baseline to 36 sessions later. When we look at the change in muscle size on the y-axis with those two groups on the x-axis, blood flow restriction in red, the control in blue, we can see that in response to very slow walking in combination with blood flow restriction, that appeared to increase muscle size over a group doing the same exercise without blood flow restriction. And they found the same thing with the change in strength, noted here on the y-axis, those same two groups on the x-axis. Blood flow restricted walking increased strength to a greater extent than a group just walking without blood flow restriction. Again, suggesting that there may be a treatment effect in certain populations. Now, the potential mechanisms involved behind the second phase, cell swelling has obviously been put forth, but I think it's also worth considering mechanotransduction, given that in this phase we're actually having individuals walk, so we're actually getting some muscle contraction. So we have to consider the activation-induced anabolic signaling. And Loenneke and colleagues investigated this a couple years ago, where they were interested in looking at the changes in phosphorylation of markers of both the mTOR as well as MAPK signaling pathways, both pathways associated with favorable changes at the muscle. So they used a within subject design where one limb was walking under blood flow restriction, and at the same time, on the opposite limb, the other leg was just walking under free flow conditions. So pictured here is the phosphorylation of the eukaryotic elongation factor 2. And on the x-axis, we have the baseline in gray, the control condition in blue, and then the blood flow restriction condition in red. And we can see that in response to walking with blood flow restriction, there was a decrease in the phosphorylation of the eukaryotic elongation factor 2. Now, in this case, a dephosphorylation of this marker would actually be favorable for changes in protein synthesis. So the overall story of this manuscript was that the signaling of mTOR and MAPK pathways appear to be favorable in response to walking with blood flow restriction. However, it's very important to note that protein synthesis was not actually quantified. It was just looking at phosphorylation, and that's a limitation. And that's why I have my final point here. When we think about slow walking with blood flow restriction, there's a lot of unknowns, and the findings are very inconsistent. And this could be due to changes, or this could be due to differences in methodology. It could be due to differences in population. There certainly are studies that find benefits, but I think that the findings are not quite as consistent as they are in the next phase. So the last phase is low load exercise. In other words, low loads meaning 20 or 30% of your max in combination with blood flow restriction. And this is the phase that has the most amount of evidence behind it. And it's where the majority of the research has centered. And it would look very similar to this. So blood flow restriction in the upper body would involve having a cuff placed at the very top of the arm. So as you can see here, part of it is covering the very top of the bicep. And in the lower body, again, the cuffs would be placed at the very top of the leg. Now, one of the common questions is, how do these changes compare to just traditional high load exercise? And that was addressed by Kim and colleagues in 2017, where they investigated 8 weeks of elbow flexion resistance exercise. And they looked at 3 separate conditions. The first was a group undergoing low load exercise in combination with blood flow restriction. They had a group training traditional high load exercise, and then they had a time matched non-exercise control condition. And they were interested in the change in muscle size and strength from baseline to 8 weeks later. When we look at the change in muscle size on the y-axis, those 3 conditions on the x-axis, the control in blue, blood flow restriction in red, and the high-low group in gray, we can see that in response to 8 weeks of resistance exercise, both of these groups saw an increase in muscle size, but there's no difference between them. However, when we look at the change in strength noted here on the y-axis with those same 3 conditions on the x-axis, both exercise groups do get stronger. However, the high load group got the strongest. And this is actually a pretty consistent finding in the literature with respect to my opinion, in that blood flow restricted exercise does increase maximal strength. It's just typically less than that observed of high load resistance training. And that's likely explained due to the principle of specificity. Now, given that the growth between low loads in combination with blood flow restriction is similar to high load exercise, one of the questions is, are the mechanisms themselves also similar, or are they different? And my opinion on this has actually changed over the past 3 or 4 years. I think the strategies used by both to activate muscle is different between high loads and low loads. However, once the fibers themselves have been activated, I think the mechanisms are quite similar at the fiber level. And I think Ellison and colleagues provide some evidence for this. And this was published about 5 years ago. This was a within subject design where they had one limb exercise with blood flow restriction and the opposite limb exercise with a high load, traditional high load training. And they were interested in looking at the gene expression response across 3 different scenarios. The first scenario is the acute gene expression response when both limbs were naive to exercise. In other words, the untrained state. They then looked at the change in the resting levels of these genes following 12 weeks of both types of resistance training. And then lastly, they looked at the acute gene expression response again once both limbs were in the trained state. And basically what they found is that anytime a gene changed one direction in a high load limb, the blood flow restriction limb saw a very similar directional change. Or anytime the high load limb did not result in a change, the blood flow restriction limb also did not result in a change, suggesting again that at the fiber level, these changes may be very similar. And I think if we look at other data at the fiber level, it would seem to corroborate this. On the y-axis here is the direction of change. On the x-axis, we have the time course following exercise. So early on, we can see changes in mTOR and MAPK signaling, activations of satellite cells, increases in protein synthesis. A little bit later on, we see downregulation in the markers associated with protein breakdown. And I highlight this just to show that these are the same changes, or very similar changes, that we'd expect to see from just traditional high load exercise. So again, I think the mechanisms of growth at the fiber level are probably quite similar between the 2 loading paradigms. However, strength, I think, might be a little bit different. I think when we look at the explanation for strength, especially in the blood flow restricted area, we often assume that any change in strength is due to changes in muscle size. However, my research group has spent a lot of time over the last 3 or 4 years trying to investigate experimentally whether or not a change in muscle size is actually causal for a change in muscle strength. And we've not been able to find a link between the two in response to experimental research. So I think we might need a little bit more work here. In fact, even when we apply mediation analysis, where you can look at both the direct and indirect paths, what we find is that in response to resistance exercise, those who lift weights do get stronger, and that's dictated by the direct path. However, when we look to see how much of that was mediated through a change in muscle size, in other words, the indirect path, we find no relationship at all. So I'm not certain whether or not the change in muscle size is actually explaining the strength change observed following blood flow restricted exercise or even exercise in general. So if it's not muscle growth, I think some other considerations could be obviously neural. In other words, some sort of change in the brain, the spinal cord, or the alpha motor neuron itself. But I think it would be a mistake to rule out qualitative changes or changes at the muscle that are occurring independent of growth. And I think if we were to look close enough, we might find some changes at the fiber level itself. But ultimately, I think we need a lot more work on explaining why individuals do get stronger following blood flow restricted exercise. So in summary, the first phase, the application of blood flow restriction without muscle contraction, this has some evidence, not a lot, but some that suggest that it can slow down the loss of muscle size and help maintain function in the face of immobilization. When we combine blood flow restriction with very slow walking, we're able to see some changes in muscle size and strength, as well as increases in functional performance in certain populations. And then when we see the low lows in combination with blood flow restriction, this is where we see the greatest amount of adaptation. In other words, changes in muscle size that are similar to and often equivalent to that of high load exercise, and also increases in maximal strength, albeit usually to a less extent than high load exercise. So given that blood flow restriction is efficacious, I think it's important to consider what's the best method of application. And two of the factors that have to be considered when applying blood flow restriction is the size of the cuff to which you're using, particularly the cuff width, as well as the size of the limb to which the cuff is being applied. And I think if we look at the blood flow restriction literature as well as the surgical literature, it's pretty clear that a wider cuff requires less pressure than a narrow cuff to reduce blood flow. It doesn't mean it's better, it just means that it's different. And that's because of the function of the size of the cuff. When we look at the limb size, those who have smaller limbs, on average, require a smaller pressure or a lower pressure than those who have larger limbs. So when we apply the pressure, we have to account for both of these factors. Now, luckily, both of these factors can be accounted for by a single measurement. And this is what we call making it relative. So you can make it relative to both of those factors by taking whatever cuff you're going to use and applying it to whatever limb that you're looking to exercise, and then measure the pulse distal to where that cuff is applied. In other words, to illustrate that in a cartoon, we take whatever cuff we're going to use, apply it to in this case, the arm. We then slowly inflate the cuff until we get to the lowest pressure at which there is no blood flow. And that's termed the arterial occlusion pressure. So if that's 100 millimeters of mercury, we would apply a percentage of that. So our lab commonly uses 40%. So in this example, we would apply 40 millimeters of mercury. And that would ensure that blood flow is always coming into the limb during exercise. And doing this accounts for both the cuff you're using, in other words, the cuff size, the cuff material. It also accounts for any individual characteristic of the person of which you're applying it to. Now, some question whether or not relative pressures are that important. And I think, particularly in a clinical setting, it's pretty important to know the pressure that's being applied. I'm going to attempt to illustrate this by showing you the impact that the relative pressure has on three variables: blood flow, blood pressure, and discomfort. So when we look at the influence of relative pressure on the change in blood flow, which is noted here on the y-axis, and the different conditions will be on the x-axis. Pictured here is the change in blood flow following the second set of exercise in the middle of the rest period in response to just regular exercise with a low load with no blood flow restriction at all. So we can see that blood flow increases substantially into the limb. When we look at the same exercise with a moderate pressure, in other words, 40% arterial occlusion, we do see an increase in blood flow into the limb as we'd expect, but it's less than that of the same exercise without blood flow restriction. And importantly, when we look at the same exercise with the highest relative pressure, we do see a change in blood flow into the limb, but it's less than that observed at the moderate pressure and less than that observed of the free flow condition, highlighting that the relative pressure applied does change how much blood flow goes into the limb. When we look at the influence of the relative pressure applied on the cardiovascular response, in this case, cardiovascular response meaning the change in systolic pressure, which is noted here on the y-axis, with the different conditions on the x-axis. So we have the response to 10%, 15%, and 20% 1RM in combination with a moderate pressure. So to illustrate the influence of a higher pressure, we'll look at each one of these loading patterns in combination with 80% arterial occlusion. And we can see that in response to the same exercise, the change in systolic pressure is augmented. So it's not augmented to dangerous levels, but it does illustrate that the relative pressure applied does change the physiologic response. Lastly, when we look at the influence of the relative pressure on the rating of discomfort, noted here on the y-axis, with the different conditions on the x-axis, pictured here is just the discomfort response to normal low-load exercise in the absence of blood flow restriction. So that is associated with some level of discomfort. When we do the same exercise with a moderate pressure, we get a slight bump in the rating of discomfort, which is markedly increased when we do the same exercise at the highest pressure. Again, just illustrating that the relative pressure applied impacts not only the blood flow into the limb, the blood pressure response to the exercise, but also the discomfort associated with that exercise. Now I'll finish by just discussing briefly, what does someone do if they don't have this type of equipment? What if you don't have a device that's able to regulate the pressure? Can you still do blood flow restriction and still have some idea of the pressure applied? And this has been a question that we've been interested in for quite some time. And we published a paper on this topic a couple of years ago where we wanted to try the method of setting the pressure relative to a resting arm circumference and compare that to a known pressure with the Hokanson device. The Hokanson device is a device that's commonly used with blood flow restriction to help regulate the pressure. So we combined resting levels. We combined 40% arterial occlusion to a condition that was pulled to 110% of the resting arm circumference, and then again 80% to 120% arm circumference to see if we could get in the ballpark at all with these estimates. And what we found actually surprised us. It was very good news. On the y-axis is the absolute change in blood flow, and on the x-axis we have kind of two different pressures. We have the lower pressure, and then we have the higher pressure, with the pressurized device in blue and the practical device in red. And what we can see is that at both of these pressures, the pressurized device and the practical device led to a similar reduction in blood flow, suggesting that this may be a viable method to help apply a relative pressure in practice. But it's important to realize that this was only done at rest. We don't know what this looks like during exercise. So in summary, blood flow restriction does increase muscle size and strength with low loads and intensities. When we look at the last phase in combination with low loads, we see a much greater amount of adaptation than slow walking. And this is likely related to the amount of muscle that's activated. And cuff pressure should be made relative to the cuff used and the size of the limb to which it's being applied. This can be accounted for by taking a single measurement. And I'd like to just acknowledge briefly my team. They're my colleagues, Takashi Abe, as well as the rest of the students in my lab who do all of this great work. I really appreciate it. And again, thank you for the invitation to speak here today.
Thank you very much, Jeremy. We've got some questions coming, which is fantastic. So if anyone's got any other questions, we'll cover them at the end in the 10-15 minutes after Stephen's presentation. So do you want to turn your video and turn on your video and unmute your mic, Stephen?
Yep.
Excellent. And you should be able to share your screen as well. We are on. Amazing.
Okay.
Right. I will leave it up to you. Thanks, mate.
Thank you. Okay. Thank you very much again to Loenneke for setting up the invite to talk today, and again to Jeremy. It's good to finally sort of do something with him here. We've been sort of talking for a number of years, so it's been a good opportunity to get to chat and sort of share some information for everyone today. So my talk is going to sort of cover the idea of using blood flow restriction for rehabilitation from injury. Now, I'm going to try and cover some of the information that's out there, some of the work that we've done in our lab, but sort of use some of the information that's out from other labs as well. And whilst in some areas there isn't aspects of research available, I'll sort of try and just sort of decide for you whether or not you think this could be used and so on. So just as a brief review, and I'm sort of wary that Jeremy's covered quite a lot of this, so I don't want to sort of waste too much time with it. But obviously from a point of view, blood flow restriction is when we perform some form of exercise, normally resistance exercise with partial occlusion. The key things that we have with it is that it's low load training, so normally 20 to 40% every 1 repetition max. And this is where it becomes quite important from a rehabilitation perspective. When individuals who maybe are load compromised can't lift those usual heavy loads that they need to get those adaptations and strength and muscle mass that Jeremy discussed. From a pressure perspective, we're looking at things such as 40 to 80% limb occlusive pressure or arterial occlusive pressure, which you will see used within the literature itself. One of the key things that we also look at is this idea of potentially keeping this continuous restriction. So the restriction occurring throughout all of the phases of the repetitions and sets. And if you look at the literature, it's a pretty mixed bag. And I'm sure Jeremy will acknowledge that you either have people going to sets to failure, or you have the situation where people are doing this sort of 75 repetition scheme, which is 30, 15, 15, and 15, with rest periods in between 30 and 60 seconds. So what actually happens during blood flow restriction? Well, I always like to show this figure because it gives you a nice indication of what's going on at the muscle itself. And this is using muscle oxygenation from a NIRS device. And this is taken from Loenneke and Clark way back in 2009. And if we look at the dashed line, you can see here that at 0% here, the oxygenation has just been normalized and zeroed. And essentially, once we start exercising, we get a decrease in muscle oxygenation. You get little fluctuations, which is just your contractions every time you do the exercise itself. And we get a reduction of oxygenation of about 40%. When we stop the exercise, the muscle oxygenation comes back up to 0, and we actually get a little bit of an overshoot there, which is just a hyperemia, so we get an increase in blood flow into the muscle itself. All that happens here is this hasn't been normalized again. We start the second set of exercise, and we get a decrease. And the decrease is of a similar magnitude as it was in the first set. Again, once we finish our contractions, we get back to normal again, and that little overshoot. So that's what happens during the low intensity exercise. The same thing would happen if that was heavier loads also, and the only difference would be that the number of contractions would be less, and therefore the amount of time with that deoxygenation would be less. When we then do low intensity with blood flow restriction, what happens is you see here at the beginning when the cuff's inflated, we actually get a little bit of an overshoot, and that's just the cuff pushing some blood flow into the muscle before we actually start. We get a gradual decline until we start the exercise. We get a decrease in this oxygenation down to about 50%. One of the key things happens here is when we stop doing the contractions and we are in our rest period, the cuff is not released. And you can see that oxygenation starts to creep back up towards rest, but never ever attains resting levels again. So in this case, about 10% difference. So by the time we start our second set, the muscle is already deoxygenated and we are already under some form of fatigue, and we start our second set. It's only at this point when we release the cuff does the oxygenation come back up to rest again. So essentially, and this is just a short version of this, it's only 2 sets. We would normally do 3 to 4 sets. So we're undergoing in some aspects a local hypoxia within the muscle, which is potentially leading to some of the mechanisms that Jeremy mentioned. So as I said, I was given the task today to discuss with you some of the applications that potentially blood flow restriction can have for rehabilitation. Now, I've taken this from Jeremy, so hopefully he doesn't mind too much, but this is just part of the slide that he showed at the beginning. And the reason I've put this part of it up, and I'll actually show the rest of it a bit later on, is whenever we think about what happens during injury, this is a model proposed by Jeremy back in 2012, and it's a really nice sort of idea of thinking about what goes on during normal circumstances. So for example, if we look at the first position here, whenever we have any period of either bed rest, immobilization, putting an athlete in a boot, anything like this where we're having any period of unloading, what happens is we get a decrease in muscle size, okay? And that can happen at a very rapid rate, within about 3 to 4% of muscle mass loss within 5 days. So it's happening at a very, very quick rate. And therefore, from a rehabilitation perspective, it's something we need to sort of think about and look out for. We then have, just in a normal phase of, you're trying to reambulate again, we're trying to get people moving, we're just doing periods of walking, trying to get people, as I said, return sort of flexibility, functionality, and so on. And actually, all that's happened there is we're not getting any change, for example, in a muscle mass by just walking around or cycling low intensity. We then perform some form of resistance exercise. And again, whenever we're injured or we are load compromised, the loads that we tend to use are a lot less than what we would normally use to create an adaptation. So the outcomes, whilst we get some improvements in strength and muscle mass, they may not be as great as what they potentially could be. So there are a few studies here which Jeremy's covered, and I will briefly just sort of go through them, but good to see that we're sort of thinking along the same lines. The first is this idea, as Jeremy mentioned, about this passive blood flow restriction. So using blood flow restriction to think it back to that very first stage, can we offset some of the muscle loss that we potentially see during either immobilization, bed rest, and putting boots on and so on. And we see this from this early Takarada study, which used this passive blood flow restriction model. And essentially all it was 5 minutes of occlusion with 3 minutes recovery repeated twice a day during a period of bed rest, in this case 10 to 14 days. As Jeremy mentioned, the passive blood flow restriction group were able to attenuate the muscle atrophy losses by about half. So if we think about that from a rehabilitation perspective, in a short time frame where we lose a lot of muscle, when we come back to start the rehab process, if we can prevent at least half of the muscle mass loss and potentially strength losses, that's going to leave us in a much better place to begin with when we start the full rehabilitation aspect of the training. Again, this was backed up by Kubata in 2008, as Jeremy mentioned, and they looked at 2 weeks of immobilization in a cast itself. And again, the comparison was the control, the isometric, and the blood flow restriction group. And essentially, what they were able to demonstrate was that the blood flow restriction, this passive blood flow restriction modality, was able to not just attenuate muscle mass losses, but also attenuate some of the strength losses that would go with it. So there was some sort of common theme here with the original Takarada study, that we can potentially attenuate muscle mass loss and strength with just using passive blood flow restriction. The same group later on then used a similar protocol, but used slightly different pressure. So they used a high pressure, which is about 200 millimeters of mercury, and they used a lower pressure, which is about 50. And they again demonstrated that they were able to attenuate some of the losses, but the higher pressure was required in order to fully stop some of the strength and muscle mass losses. So how can we apply that, and what does it mean? So this is a very recent study out of Brazil, which is sort of going to the very extreme end of rehabilitation, but it's looking at intensive care unit patients who are in a coma. Essentially what you have here is you've got one limb which is a control leg, and then one limb using a passive blood flow restriction model. They used 80% of LOP or AOP, and then they had a physio who did some passive mobilization, which was just 3 times 15 reps of knee flexion and extension. So the physio was moving the limb in these patients who were in a coma. And in section A there you have your muscle circumference, and B you've got your muscle thickness. And the dark circles are essentially your blood flow restriction, and the white are the control. And you can see here just from plotting the line of best fit through the blood flow restriction and the control group, that overall the blood flow restriction seemed to attenuate some of those declines in both circumference and thickness in comparison to the control group. And that goes across from the longer you stay, again, they were better able to stave off some of those muscle mass losses that you would expect to see. And again, especially from an intensive care unit aspect, a lot of the patients, unfortunately, don't actually come out of intensive care, but more importantly, it's a long road back to full recovery and rehabilitation. So again, muscle mass is a really key aspect here with these types of individuals. Whilst we know that passive blood flow restriction can have this role with regards to muscle mass and potentially strength, and as Jeremy mentioned, it's not all plain sailing. There are a few studies which are potentially saying that it maybe doesn't have as positive effect as what you would hope. The way we apply this passive blood flow restriction is very similar to another terminology known as ischemic preconditioning. And again, it's just this idea of applying blood flow restriction passively. So it's full occlusion, so 100% limb occlusive pressure for 5 minutes on and 3 to 5 minutes recovery periods. And you need to do this acutely, but what we've demonstrated, Owen Jeffries out of our lab a few years ago, demonstrated that if we apply this ischemic precondition or passive blood flow restriction, we can actually get adaptations at the local muscle level as well with regards to blood flow and oxygenation. So sometimes we think with a rehabilitation perspective, we're always thinking about muscle mass and strength, but obviously there's other aspects too, especially if you have someone who is rehabilitating as an athlete who has other factors to consider, not just strength and muscle mass. They've got aerobic capacity, other things to consider. So this is looking more at the periphery within the muscle itself, but we were able to demonstrate an enhanced oxidative capacity, faster kinetics of muscle oxidative kinetics itself. We were also able to demonstrate in the right-hand side here a decrease in the muscle oxygenation consumption at rest, so more efficient blood flow and muscle at rest itself. And then we were also at the bottom here, we performed exercise at 40 and 60% MVC, and found that after 7 days of ischemic preconditioning, we had an enhanced reoxygenation of the muscle following the exercise itself. So we're seeing localized improvements in both blood flow and muscle oxygenation with passive blood flow restriction following repeated cycles every day. And again, as I said, this is really important and also may help explain some of the changes that we're seeing with the muscle mass and strength aspects also. As I mentioned, one of the big issues that we have potentially with passive blood flow restriction is that the research is a little bit mixed. We have some studies which have shown some attenuation, some have suggested a full attenuation, and others which haven't shown a great deal. And one of these sort of areas where potential benefits may occur is if we add some neuromuscular electrical stimulation to blood flow restriction. So essentially take that end phase of the model that Jeremy talked about with regards to resistance exercise, but take out the contraction element from the brain, put the neuromuscular stim on its own, and that's going to perform the contractions on the muscle. So you can see here on the right hand side, we've got the neuromuscular stim on the muscle itself. and that will actually stimulate the muscle whilst the cuff is inflated. And there's been a few studies in this area. Natsumi back in 2015 looked at it and looked at neuromuscular stim zone versus neuromuscular electrode stim and blood flow restriction. The intensities are very low, 5 to 10% of your MVC. This was 23 minutes a day, twice a day for 2 weeks. And just like the normal resistance exercise with blood flow restriction, they got some improvements in things like muscle thickness and then a range of improvements in muscle strength. Now, this was a group of healthy individuals. So we would expect that if we have individuals who are immobilized and individuals who are in bed rest, if we apply this model, we may be able to offset some of those muscle mass losses and strength losses. And Jeremy's mentioned the idea of the passive blood flow restriction, maybe working on the muscle protein breakdown element of the sort of that equation of muscle protein breakdown and muscle protein synthesis. Well, actually, because we're having contractions of the muscle with the neuromuscular stim, we're actually getting an increase in protein synthesis. So potentially seeing some growth, or in periods of mobilization, potentially may offset the losses completely. One of the difficulties we have with this neuromuscular stim work is that it's very new in that there's not a lot of people have actually been really looking into it. Paul Head, who's currently doing a PhD in our lab, has actually been doing this and looking into this in a bit of detail. And this is some work that's just been published from his PhD. And this is looking at fatigue rates with just stim alone and then neuromuscular stim with different percentages of blood flow restriction to try and start to work out if we need different pressures and what pressures are more optimal for adaptations. So with the idea being that the more fatigue that you create, potentially the greater the adaptation that we may observe. And this is just MVC before and after the neuromuscular stim. And this was 4 sets of 10 contractions. And essentially what you can see is neuromuscular stim at BFR led to greater fatigue than stim alone. But when you add stim at 80% limb occlusive pressure, it led to an even greater change in fatigue compared to the 40 and 60% group. Paul's now following that up at the minute. He's got some work that he's currently undertaking, and he's looking at a training study with the idea of looking at stimulate zone. He's picked 40% BFR and 80% BFR to try and gauge whether the adaptations are actually different. The study hasn't finished, but at the minute, we're starting to potentially see that there may not be some differences between the sort of adaptations that you get from the 40 to 80%, which again backs up some of Jeremy's work, which suggests that you may not need to go to the higher pressures to create some of the adaptations. Again, one of the other aspects that we can use is this idea of aerobic exercise with blood flow restriction. And again, this is the study from Takeshi Abe back in 2006 that Jeremy mentioned earlier on. Twice a day, walking 6 days a week for 3 weeks. Really nice, simplistic study. But where it was really important and really interesting was this idea that we were seeing potential changes in muscle size, so up to 7% increase in muscle size and up to a 10% increase in muscle strength. And if we think back to normal sort of aerobic exercise, we're not tending to see any changes in muscle mass or strength with aerobic exercise. Now, there hasn't been a great deal of work within the literature of aerobic exercise with either mainly rehabilitation injury. That's not to say it's not being used. We know it is used widely in practice, but just from a research perspective, there's not a lot out there. There's a couple of reasons for that. I think probably the main one, as Jeremy said, you get so many benefits from doing the resistance exercise that actually, instead of following, let's say, a progressive plan like Jeremy suggested, what we end up doing is we just jump straight to the resistance exercise aspect of it because we know that's very effective. There, as Jeremy mentioned, there's some inconsistency in some of the findings, but there's also some data that's just come out recently from Danny Christensen, and they've been looking really at a deep level with regards to aerobic exercise with blood flow restriction and finding some really interesting results around improved blood flow and improved adaptation, specifically within performance. And that's one thing I think we tend to forget. It always depends on who we're working with from a rehabilitation perspective. But anybody who's online today, who's working with athletes, you know, again, it's not just a matter of worrying about muscle mass strength and these factors. we also have aerobic capacity and peripheral adaptations of the muscle that we need to consider also. And potentially we're seeing that with the aerobic exercise, because we've seen improvements in performance. There are improvements in VO2 max and other things within the literature. So that can potentially sort of help and aid that aspect from a rehabilitation perspective. I guess when we started looking into this originally, this idea of rehabilitation, it was with Luke Hughes, Dr. Luke Hughes now, who started his PhD with me a few years ago and is now currently doing a postdoctoral in position and research. So one of the first things we decided to look at was what actually is happening with blood flow restriction training from a rehabilitation perspective. And as Jeremy mentioned, and he showed in one of the very first slides there, was if you look at the rate of increase in research articles that have come out within blood flow restriction, it has started to really sort of peak and started to really sort of hit the mainstream, so to speak. And back in 2017, we first looked at this. When we were looking at that, we were only able to find about 20 studies that were eligible for systematic review in the area and meta-analysis. And that only included 3 studies in knee osteoarthritis, 3 knee ligament injuries, 1 body occlusion myositis, and then the rest of them were older adults susceptible to sarcopenia. And what this basically demonstrates is back to this original idea of what we're trying to compare. If we think back to that original model, in the early stages of rehab, we're comparing low load blood flow restriction training to low load training, because you're load compromised, you can't lift, generally can't lift heavy. And this figure is just a Hedges G figure, and it basically shows, if you go to the left hand side, it favors low load training, and if it goes to the right hand side, it favors blood flow restriction training. And essentially we see a moderate effect of strength whenever we compare blood flow restriction to low load training. So at this time, there was not enough data to compare muscle mass changes. If we go and then look at low load BFR to heavy load training, in this case, to the left favors blood flow restriction, to the right favors heavy load. And again, there was a moderate effect towards heavy load, which again backs up the work that Jeremy mentioned with regards to heavy load training having a greater impact on strength adaptations. But if we think about low load blood flow restriction as that early stage part of rehab, where we're trying to put muscle mass back on, we're trying to prevent muscle atrophy, we're trying to improve strength before we can then transition them back into the heavy load training. I don't know what Jeremy, I'm not putting words in Jeremy's mouth here, but I don't know anyone who's not suggesting that blood flow restriction is better than heavy load training. All we're saying is use it as an adjunct to actually help and benefit you and sort of move you forward. More recently, again, from Luke's work, we decided to have a real deeper look at this with regards to ACL rehab. With a range of participants go through this reconstruction surgery, and then we had a randomized control trial, and they were either assessed onto a blood flow restriction group or a heavy load group for 8 weeks of training. A range of different outcome measures: strength, muscle thickness, functional questionnaires, pain scores, knee circumference, and goniometers for flexibility, and so on. It's a very, very simple study. This was just this was in a group of NHS patients. So these are people who are just getting regular surgery on the NHS and then performing surgery training twice a week as part of their rehab. On average, the blood flow restriction group started 24 days post-surgery, and the heavy load was again a very similar timeline. Heavy load group, 3 sets of 10 repetitions at 70% of their 1 repetition max. And the BFR group is the 30, 15, 15 reps with 30 seconds recovery. Everything else was standardized. Their normal rehab that they did, the physiotherapy that they went through, we just swapped out 1 exercise, in this case a leg press, with either blood flow restriction or heavy load training to see if there was an impact. If we look at strength on the left and muscle mass thickness on the right hand side, essentially what we see is there's no difference between groups. Actually, both groups were able to improve both muscle mass or muscle strength specifically, and we get it back to pre-testing levels after 8 weeks of training. And thickness, we got a decline obviously from pre to post surgery, which started to come back up again towards the end of the training program itself. So there's no difference between the groups with regards to those outcome measures, and actually suggesting that we can potentially use sort of heavier load potentially with these patients early on. What was more interesting was that actually we were able to see better improvements with regards to functional scores. So here's a range of functional scores with blood flow restriction in the red and the high load group in the blue. So even though strength and muscle mass may have been similar, functionally patients were reporting that they were feeling better, and they were able to do a range of tasks better following blood flow restriction. And that was also backed up with things like the patients seeing greater pain reduction over the training program compared to the heavy load group. They had a decrease in effusion, which was greater than the heavy load group, and they also significantly enhanced their range of motion. So we seem to be getting, despite similar changes in sort of strength and mass, we seem to be getting better improvements with regards to pain, effusion, and range of motion. And that backs up a study that we did a few years ago with the British military, where again we compared different groups in an intensive rehab unit. And essentially they demonstrated that we were able to, whilst we were able to see similar outcomes with regards to normal heavy load training to blood flow restriction, they actually were able, it was the functional outcomes which were better for blood flow restriction. So both groups improved against strength and muscle mass, but functionally the blood flow restriction group was getting better compared to the heavy load groups. So if we go back to this model that Jeremy put up earlier on, I said the bottom here is the normal progression, but if we then start to add the blood flow restriction, these different phases, potentially we're getting either a maintenance of muscle size, an increase with walking or cycling, and then an even greater increase when we start to use the resistance exercise or BFR. One of the big areas which we've been looking at a lot recently, and again this is really a lot of sort of Luke's work that he's been doing, is this idea of pre and post training pain relief. And one of the things we've seen out of a few of the studies that we did was we were starting to see, and others again have been seeing this as well, that there's potentially some benefit with regards to pain and analgesia. And I guess we weren't seeing it when we were doing all the studies on the healthy populations because nobody was in pain. But once we started working with more clinical groups, they were starting to report this. And there's been a range of groups that have done this. This is from a group over in Aspetar who looked at anterior knee pain, and they found that blood flow restriction was able to reduce knee pain for 45 minutes post-exercise. So just again, one bout of blood flow restriction exercise. This is from Lachlan Giles and Jill Cook's lab. And again, this is over a period of time. It's a training study over a period of time itself. But again, they found a 93% reduction in daily pain scores with the blood flow restriction compared to, again, a heavy load group with people with patellofemoral pain. We found something very similar with regards to our ACL study. We found that 63% reduction or so in pain across the time frame. What we also did, we did an acute aspect of that study. And on the left-hand side, you've got knee pain. And this is session knee pain score during exercise. And then this is 24 hours on the right-hand side after the exercise itself. Got your ACL, blood flow restriction, and then the high load group. And essentially during the exercise, we found that knee pain was less during the exercise itself. And that kind of makes sense. The ACL heavy load group, we're just in a heavier load compared to the blood flow restriction group. Therefore, there's more pain going through that joint because it's not used to lifting those heavier loads. What was interesting was 24 hours later was that pain was dramatically reduced with blood flow restriction, and in the heavy load group it wasn't. So we're starting to see changes, and it was more than what we'd seen in the previous work, and it was lasting up to 24 hours. What was very interesting was within the blood flow restriction group, they were having muscle discomfort within the muscle itself, but within the knee, which was obviously had the surgery, there was no discomfort and less pain. So Luke very recently published some work in the Journal of Applied Physiology, and we decided to sort of try and take a step back and have a look and see what's going on here and what's happening. And this is a group of healthy individuals, and it's looking at blood flow restriction or low load on its own, blood flow restriction with 40% LOP, 80% LOB, and then high load resistance exercise. And essentially we are taking a range of pressure pain thresholds, and we decided that we wanted to have a look and see, well, what's actually happening and where is it happening. So we have the dominant quadricep, which was the muscle that was worked. We have the non-dominant quadricep, so this muscle did not do any exercise. We've got the dominant bicep, so it's above the cuff itself, and the non-dominant trapezius, so again, above the cuff, but non-dominant. So what happened? Well, essentially what we've seen was, this is 0, 5 minutes post, and 24 hours post for your black, dark grey and grey bars. And essentially, across the board in dominant limb, exercise had an impact at least up to 5 minutes in reducing pressure or increasing pressure pain thresholds. So essentially, you put a little device into the muscle and then you push it against it and see how hard you can actually take it, and it will give you a reading. And essentially, so all exercise had this 5-minute improvement on pain scores, but the blood flow restriction groups had an even greater increase, with the 80% blood flow restriction group having an even greater increase than the 40%. And it was only the blood flow restriction training group that had an increase at 24 hours. So the other heavy load training and low load training had a pain improvement in pain scores, but this came back after 5 minutes or so, whereas the blood flow restriction lasted for 24 hours. Again, if we look at the non-dominant quadriceps, again, across the board, this happened in all of the conditions, this acute 5-minute phase, but again, the 40 and 80% group were greater than the low load or high load group on its own. And this happened across the board for the upper body as well as the lower body. So we know that there's a systemic effect as well as a localized improvement in pain threshold. And where people are starting to use this a lot now is obviously from an athletic perspective, people are using this to help them obviously whenever they're rehabilitating, when actually they're in pain, but also, you know, with athletes who've got constant niggles, always trying to get out onto the field and so on, they're starting to use this to try and help them improve their ability to actually withstand load and actually do some training sessions and so on. There are some potential risks and caveats there. Final thing in this aspect is that we also did some mediation analysis and essentially found that the greater the muscle discomfort, the more benefit you have from a pain perspective. So Jeremy demonstrated really nicely on the slide there that when you change the sort of pressure from 40 to 80%, there is this increase in other aspects, and there was a big increase in muscle discomfort. What we've found is that that greater discomfort actually is beneficial to reduce pain. And I think you have to weigh up where you use it and actually from an adaptation and from a pain response aspect. So plenty of little things to think about. Like this study here, it's not really anything to do with rehabilitation, but I put it up for one reason, and is that one of the things that we always gets thrown back at people, especially with regards to blood flow restriction, is the idea of, well, what happens to tendon? And actually, are we at risk if we increase the muscle mass, increase muscle strength, that we actually are having detrimental effects to the tendon long term? It's never obviously worried me too much because I don't think we use blood flow restriction long enough for that to happen. So you're never going to get a stage where that's all you use and you're going to have this negative effect. This early work by Kubo back in 2006 demonstrated that high load training had a greater improvement in tendon stiffness, but blood flow restriction did not. But a recent study out of Germany from Sentner et al. Actually demonstrated that there was some potential improvements in tendon stiffness and tendon cross-sectional area with blood flow restriction. And what they did do is they progressively increased load up to 35%, just like they did in the high group. But this was the first study that's really shown some tendon adaptations. We need a lot more work to confirm and to sort of validate that these are going to happen at different aspects, but it is certainly interesting that there could be some potential tendon adaptations with BFR. So finally, before we finish up, is around the idea of programming recommendations. So last year, yeah, I think so. Last year we put together this sort of guideline paper, and which Jeremy was involved with another group of researchers all over the world, just to sort of try and put together, come up with a sort of some form of consensus about how blood flow restriction can be used and some of the ways it can be used. And this is in Frontiers, and if you want to check it out, it's free access. But it gives you a range of different recommendations with regards to frequency, how many times a week, how many times a day you can use it, the loads that you should be using, how long you should apply pressure for, and so on before you reperfuse, number of sets, and so on. And it's pretty self-explanatory, but it's a sort of, you can imagine it's pretty generic sort of table here, but it's sort of trying to get guidelines that everyone agrees on to sort of make recommendations for programming. That's just for your resistance exercise, and there's also one for aerobic exercise also. So thank you, and any questions?
Thank you very much, Stephen. We haven't got loads of time. I don't want to keep you for too long. But one particular question that I did pick out that may be worth jumping on was a question for Jeremy, but you brought it up as well, Stephen. And that was, are there any risks to starting BFR phase 1 so soon after an operation? That was actually directed at you, Jeremy, but that was before Stephen had mentioned it. So I'm going to come to you first, Jeremy.
Yeah, I'll start by saying I really don't know. I'm not a clinician. I think what I always tell people is I typically perform research on normal, healthy individuals. So I provide information with what typically happens, and then I allow clinicians to take that and mold that with their clinical expertise. So I'm sure there are certain contraindications that need to be considered. Stephen might know that better than I, but I would say probably so. There's probably things you need to consider, but I would be way out of line to try and give recommendations related to that.
Yeah, look, just to back that up, I'm a little bit like Jeremy. I don't want to sound like a bit of a fraud here, but we're in a situation where, as a physiologist, we're sort of making recommendations about how you can use things rather than from a clinician's perspective. Even though we're doing some of this research, we will do it with clinicians in mind. I think one of the things before you do anything, the biggest issue you're going to have is your surgeon. And they're the ones who are going to dictate what you can and can't do a lot of the time. So that's going to be probably the biggest driver on when you can start. The one thing to keep in mind is, for example, I mentioned passive blood flow restriction is a little bit like ischemic preconditioning. Well, they do an ischemic preconditioning during heart attacks. They're doing ischemic preconditioning too. So it's having a positive effect in some aspects. So I don't want to stand here and say it's 100% safe, because I don't think anything is. But I also, I think it's less worrying than potentially what people think. I think you just have to be wary of, for example, what drugs they're on. Are they on anticoagulants? Are they on other things that, again, they may sort of impact it? So I think this is probably why people have stayed away from it from a performance perspective. And I guess the one thing I would say is, what is it you're trying to achieve? I guess it depends on the injury itself. And actually, do you need to get right back in the very first day post-surgery? Do you actually want to give some people time to heal and recover before you then apply blood flow restriction? I think that's the thing you need to weigh up.
Excellent. Well, there's a couple more questions there, but I don't think we're going to have time to get through it. And I was wanting to be get through things pretty sharpish and let you guys get on. But is there any place where they can follow up with these questions individually on social media or something like that? Is that possible, Jeremy?
Yeah, Twitter is where I'm probably easiest to communicate with, at JP Loenneke. I also have Instagram, but I struggle with responding on Instagram. Twitter is the best place for me.
Okay, excellent. Same with you, Stephen?
Yeah, definitely. Even though I have Instagram, I find it difficult to work. Show me.
Yes. Okay, so Twitter's the best place for both of you. So if anyone's got any questions that we haven't managed to get through, just follow them on Twitter and drop them a message. So thank you very much to you both, and thank you very much to the guys at Occlusion, Cuff and Lock for sorting this out. And thank you very much. Yeah, over and out.
Thank you.
Cheers.
Thank you.